Okay, so I'll go ahead and get started then. As Megan said, this is session two of the ECHO, and specifically we'll be focusing on assessment of behavioral and psychological symptoms of dementia, um, by way of sort of explaining a little bit about who I am. So I'm a geriatrician at St. Michael's and Providence Healthcare, which are part of Unity Health in Toronto, and then I'm also an assistant professor at the University of Toronto as well. So for disclosures, I hold research grant support from CIHR, which is the Canadian Institutes of Health Research, as well as the Providence Healthcare Foundation. And I received an honorarium from the CCSMH related to the work in developing the guidelines, some of the recommendations that we'll speak about today, but no other disclosures. And just to say that the program received financial support from the Public Health Agency of Canada to the Canadian Coalition for Seniors' Mental Health in the form of an educational grant through a co-development agreement with the CCSMH. Um, and then these slides speak to mitigating potential bias in the CME program, knowing that all the recommendations that we make are based on the best evidence and recommendations from the clinical practice guideline. Okay, so here are our objectives for today. So something that you're probably already wondering about, which we will talk about for sure, is the terminology that we use for describing and documenting BPSD, and how you might decide to use sort of one way of describing a behavior or an expression versus another. Recognize when to assess for delirium in a patient presenting with BPSD, BPSD in quotation marks, because maybe it's not. Describe an approach to documenting the antecedent circumstances to behaviors, describing behaviors using person-centered language, and also understanding responses to those behaviors. So really like that sort of structured assessment that we want to use whenever we're assessing and treating somebody who's having a behavior, and then go through some of the tools that we can use to measure and document specific BPSD, and making sure that we're using sort of person-centered approaches and to be able to show that, when we're implementing an intervention, that it's having a clinically meaningful impact on the patient and the caregivers. So to get started then, are BPSD the same as responsive behaviors or personal expressions? And this came up during the guideline development process and also, after the guideline was launched, in terms of why do we use certain words or why do some people use certain phrases and other people use different phrases. And so we did try and look into this, with a scientific lens as best we could. And the short answer is that, some people use the phrase BPSD, behavioral and psychological symptoms of dementia. And I'll go through some examples of terms that people use whenever they're using that sort of lens to describe behaviors. And other people use more what we term sort of the person-centered language, and this comes out of, when people are using terms like responsive behaviors or personal expressions, really suggesting and supporting that notion that, behavior and people's like feelings that they're having are rooted in their needs and them trying to like express something that they need from their environment and from their caregivers. And so we'll talk a little bit more about that over the next few slides. So when we want to figure out more about, what language we should use for our guideline, but also in implementing the guideline and, when we're like out there on the front line caring for people with dementia. And when we looked at the terms being used around the world, BPSD was the most frequent term that was being used. But when we did a national survey, what we saw was the terms responsive behaviors and personal expressions, coming in, second and third. Within Canada, there is more recognition of the use of the person-centered language. And so we thought, that's obviously really important to consider. As I was explaining before, when people use, BPSD terminology, it's often more rooted in the research literature, and you will see this when we look at certain scales later on. And these are the terms that are in those scales, which reflects that they're used more in for research purposes. Although some of these terms we will use, in providing regular patient care as well. Although the caveat to that being that, what we often think about is if we're going to say, somebody is feeling sad or somebody is feeling depressed, we try to, it doesn't just stop there. Obviously, we try and figure out, why that is. Again, with that understanding that behavior and feelings have meaning, and we need to try and support uh, that person as one of their caregivers and to improve their environment for them. Versus in a lot of our, hospital settings or institutional settings, there is a movement towards using more concrete language really to describe what we're seeing and where it's happening, and what may have precipitated the behavior and what the response was or what happened next. And so what I've got here is just example of documentation from St. Michael's Hospital where I work. And these are the sheets that the constant care provider is asked to complete. And so um, it's not perfect, obviously, but what I mean to show is just that, we don't just say agitation, right? We're trying to get the care provider to say exactly, what the behavior was that they saw and, what the response was and where it happened so that we can try and develop that person-centered care plan. So moving on, delirium, because as I said, for objective number two, we need to think about, when we're assessing somebody for behavioral and psychological symptoms of dementia, we need to be able to know first and foremost, do they actually have delirium? Because of course, delirium is a medical emergency. And so then if somebody has delirium, then we need to that should trigger a whole series of steps whereby, the healthcare team is trying to figure out, what is a medical or metabolic or like what has caused this delirium. And so I just have here a common approach to diagnosing somebody with delirium, the confusion assessment method that many of you are probably familiar with. But the key features of this being that, it has to be an acute change and there will be some, fluctuation throughout the day to somebody's mental status and level of consciousness. And then they have to demonstrate inattention, which you can informally assess, if somebody's not able to follow your commands or instructions, although I know sometimes that can just be a part of somebody's dementia syndrome. But there are also formal tests of inattention that we can use. Things like, asking a person with dementia to say the days of the week backwards or months of the year backwards, assuming they were able to do that when they were last well, because some people, if their dementia is advanced enough, can't do that. But in other people, it works well. The third part, so they need one and two. And then for the third and fourth part, so when we talk about disorganized thinking, I think one of the approaches that I use that has served me well over time, I think, is assuming that my thought process is linear and goal directed. I'm trying to speak with somebody else, and they're not very goal directed in their speech, or they're talking about this and that, and I can't follow their conversation at all. That's somebody who's disorganized. And then, of course, the fourth part being the altered level of consciousness, which sometimes it's hyperactive, but we know prognostically anyway that being hypoactive or lethargic is actually, prognostically just as important. And so recognizing changes both ways is really important. And when should you suspect delirium? So certainly if you're being asked to see somebody who has a new onset BPSD, it's always incumbent upon us to look for those potentially like reversible things that could be actually delirium related. If, suddenly there's worsening BPSD, that could also be delirium and should, make you think about, again, trying to make sure there's no underlying medical precipitant for this change. Certainly, if the BPSD is associated with other signs or symptoms of illness, if somebody has a fever or if somebody is talking about pain that like they didn't have this pain before, or if somebody's all of a sudden constipated or, having trouble breathing, for example, all these things shouldn't really make you worry that it might actually be delirium and not related to their dementia. And then, of course, if there's BPSD that you really otherwise can't explain, what has happened, then of course that needs to sort of also prompt you to be like, well, in that philosophy of behavior has a meaning and people are trying to communicate a need to us, you know, if you can't otherwise identify something, then, to go looking for potentially metabolic or other medical reasons that somebody is manifesting this symptom that you're seeing. And so, how do we approach understanding somebody's BPSD? And I'm sure that you're all familiar with sort of different approaches that people might have. Um, and there are different approaches out there, and they can often be used sort of together in concert to really help us understand the person with dementia, their needs, and trying to support them to uh, and their caregivers to be able to, live as best they can, improve their quality of life, and to reduce the burden from their BPSD. And so I often think about things in terms of this approach that I'm going to give to you over the next few slides. And actually, this is an approach that I use for all of my geriatric syndrome assessments that I do, whether it be somebody's had a fall or I'm seeing somebody for delirium or functional decline. I always think about things this way. I think about, what are the protective factors that might help them to have less BPSD than somebody else. Like, for example, we know, if they've got a familiar carer, if they're in a familiar environment, if they've got a caregiver or carer who's really knowledgeable and has a good tailored plan of care. That's also important. Having supports for the carer there to be able to deal with some of the distress and burden that they may experience, of course, and minimizing those sensory impairments as well. Then we might also think about predisposing factors, so things that could make it worse, whether it be related to the person themselves, the environment, or things that are impacting their carer. And those are some examples there. Then we also want to think about, what precipitated this behavior or psychological symptom that I'm seeing right now? Is there an acute trigger that I can identify? And then perpetuating factors as well. So you can always break it down into these four things for geriatric syndromes in general. And if you want more information, actually, this is in a clinical update paper that I worked on with some team, including a person with lived experience a couple of years ago. And the citation is below. So whenever I was talking about those four things, the predisposing, protective, perpetuating, and acute precipitating factor, as I said, those are always in the context of, what's happening to the person living with dementia, what's happening to their caregiver, and what's going on in the environment. So I always also think about those three components. And then many of you will be familiar with the PIECES approach. And so PIECES stands for physical, intellectual, emotional capabilities, environment, and social. And I use this mnemonic to really help me think about, the things that are described here and how they apply to the person with dementia, their carer, what might be happening in the environment. And then again, I think about, what's protecting the patient, what are the predisposing factors, what are the perpetuating factors for the behavior I'm seeing, and what is the acute precipitating event. And then, of course, when we're talking about the behavior itself in that moment, you can then layer on the ABC approach, and this is what we were talking about earlier in trying to really use very person-centered language and understanding, in that moment, using the best sort of specific language that we can to describe the symptom. And this is in terms of, antecedent. So like what was happening before, what specifically was the behavior and what happened in response, or like what was the consequence, how did we react, or how did we support the person, and did that help or did it make it worse? And all of this can many people again are very familiar with the dice approach. Today we're not talking about the whole dice approach, but we're certainly talking about, describe, we're trying to describe the behavior, describe the person in their whole context, considering their caregiver and their environment, and investigating those potential, predisposing and precipitating and perpetuating factors that might be worsening the behavior that we're seeing. Okay. And then very briefly to touch on some tools that we talk about in the guideline that you may consider using to objectively measure uh, the behavior that you're seeing and potential changes. Keeping in mind that some of these, you may immediately be thinking about, well, clinically, like how feasible is this, Jen? And I would agree, but it's also potentially important given some of the terms that are used and in certain circumstances more than others. So, for example, the Cohen-Mansfield agitation inventory is quite long, as you can see there. And so, it's used in the research setting a lot. Many of the randomized trials that have informed the different interventions that we used have the Cohen-Mansfield agitation inventory as the measurement tool that they've used to show that an intervention works or not. Clinically, what I like to use it for is all the different specific terms that they have there. And whenever I showed you in my institution at St. Michael's, they have specific terms that we can use to describe behaviors. It's not all encompassing though. And so often I'm using that other box to try and describe what I'm seeing. And some of the terms here in the Cohen-Mansfield agitation inventory can help you to like sort of expand the terms that you have to describe the behaviors you're seeing. So the Cornell scale for depression and dementia, uh, you know, it's really good to use for trying to measure the symptom burden related to depression or depressive symptoms in people with dementia. Because as you know, not everybody who has depressive symptoms meets the clinical criteria for having depression. What's really nice about the Cornell scale for depression and dementia, and it does have like very good evidence from a diagnostic tool perspective, is that it incorporates the caregiver input as well. So it's the person with dementia, but their caregiver is really providing a lot of input here. And as you can see, it focuses as well on some of the like physical manifestations of the depressive symptoms that we know are really important to measure in terms of symptom burden in people with dementia. And for measuring symptoms of anxiety, the rating anxiety and dementia scale also has very good evidence. And again, this is a scale that incorporates the perspective of the carers as well, which I think, again, is really helpful. And the other thing that it also does, like the Cornell scale for depression and dementia, is that it also measures those physical symptoms that, again, we know are really important to understanding symptom burden in people with dementia because, they may not always be able to tell you exactly how they're feeling, but you can tell, by looking at some of the physical signs and symptoms that you're seeing that, they're very anxious or they're worried about something. And so the RAID scale, as it sometimes gets called, is really helpful from that perspective because it helps us to incorporate those signs and symptoms that we can see in people living with dementia. So I know that this is a very busy slide, but this is the approach that we recommend in the guideline for recognizing and assessing and describing sexual behaviors of potential risk in people with dementia. And so this is called the St. Andrews Sexual Behavior Assessment Scale or the SASPA scale. And I think what's also really helpful about this is it uses that approach that, if you think about the ABC approach, like what was happening before the behavior, exactly what happened, and so we've got the four categories here for the behaviors, whether it's verbal and as you go down, so you'll see on the on my far left, you've got one, two, three, and four. One being sort of the milder of the symptoms, but by the time you get down to four, it's a very like a sort of the most distressing or the worst symptom burden down at the bottom there. But you have them divided up into verbal comments, sort of non-contact exposure, and then actually touching others, which I think is very important. And then understanding, what happened next. So, what was the response and how did that help? Can be sort of the next pieces to help us understand. So it's really intuitive from that perspective, following that ABC approach. But what's really good about this in particular is that it gives you categories, it gives you lots of words to describe what you're seeing and what happened. So lastly, I want to talk about person-centered goals and goal attainment scaling, which some of you may be familiar with already. I hope so. It's something that is we use in geriatric medicine, and there is increasing evidence that it's helpful for people with dementia as well. And so it's nice because it's reflecting, exactly the responsive behavior or the personal expression that the person is having, and you use terms to exactly describe what you're seeing. You don't need to put it on like a scale that gets used in a research study somewhere. And, say that you are seeing, somebody who is asking for food all the time, as the example is here, and that is their baseline. So the thing here is that you actually work with the person living with dementia and their carers to actually sort of develop a clinically meaningful scale of improvement or worsening for the particular behavior that or psychological symptom that you're seeing. And the baseline, the no change or expected, is seeing right now. And then you work with the person with dementia and their carers to say, okay, what would be a small worsening or like a lot worse compared to what you have right now? And similarly, what would be a small meaningful improvement and what would be a large meaningful improvement? And so then sort of what everybody is hoping to see, like what would be a meaningful change for everyone. And so whenever you do say what the intervention or interventions is going to be, then this is how you measure if you had meaningful improvement or not, and how you describe if you're going to continue the current therapy, perhaps increase in intensity of the therapy, or perhaps, de-implement a non-pharmacological intervention that didn't work or de-prescribe a medication that didn't work. So this approach can be very, we're developing person-centered goals, hopefully using person-centered language. And so in summary, as I was saying, choose the language that works the best in your context. So, we know sort of BPSD, behavioral and psychological symptom type language, gets used a lot in the research literature. It's still very much terms that are used in the published literatures in guidelines from around the world. And so it has a really important place there in how we're communicating about, the work we're doing to these people who are developing international guidelines and doing studies and things. But we also know, at the bedside that using person-centered language, talking about, the meaning behind behaviors and expressions is really important too. And so, use the language that works best where you're working. And then always to consider whether BPSD is actually delirium. And so some of those things that we talked about, it's new onset, it's worsening, you can't otherwise explain it, or it's associated with signs and symptoms that really make you worried. There's some kind of illness, like systemic medical process that could be driving the behaviors. And then, of course, trying to apply an assessment approach that's, considers all the factors related to the person living with dementia, their caregivers, and the environment is going to be really important. And then, whenever you're going to be prescribing or making a treatment plan, always making sure that you have a target set for, what would be a clinically meaningful improvement in symptoms and behaviors so that you have a clear idea of, when you try to check, what sort of progress have you made, how you're going to decide if, you continue on or if you need to make changes. So thank you very much.
Thanks, Jen. We have some time for Q&A, and we do have a question in the chat from Una. I will just read it for people who maybe don't have the chat open. It says, I'm struggling with how to support people with dementia in the community when I'm the first point of contact, family physician. Obtaining this history takes time and compassion, and folks are often at a crisis level when they contact us. I'm curious how others providing primary care manage to support people with dementia when other services are not in place or won't be in place for a while, given time constraints. So, I mean, if other people want to respond, we can, you can raise your hand or you can type in the chat. But I'll open it up to you first, Jen.
So that's a great question. And course, where I work, I'm not often that first point of contact. And so, for me to sort of speak from my lived experience of that is a little bit challenging, although I do have an outpatient practice and a geriatric medicine clinic. And so I do sometimes get calls from often patients' family members when they're in crisis or when something has changed, asking for guidance about what to do. And I think part of the challenge is that, when there's a worsening like that, or if it's a new onset behavior, of course, as I said, in my mind, I'm always like, well, is this delirium or is this just related to their BPSD or responsive behavior to something, that has happened in their environment or some change. And as you said, that can take some time to sort out. And um, it does often take like quite a lot of questioning of the caregiver and trying to understand, the full context. So that is challenging. From my perspective, a couple of things. If a patient and their caregiver are able to do some outpatient workup, if I think maybe they need some blood work or if they need a CT scan, for example, then okay, we can try and manage things in the community. But if not, then sometimes that does precipitate a trip to the hospital. And of course, delirium is a medical emergency. So that's understandable. Although, as we know, there's all sorts of hazards of hospitalization and visiting the emergency department that, we can't take lightly either. The second thing that I can say for people in Ontario, at least, is, and I think there are some people from the BSO on the line here. I've had responses from BSO. They're very responsive to referrals, and so it may not actually be sort of as long as you might be worried that it might take to be able to get some of that support. I'm not sure if there's somebody from the BSO who can speak to that a little bit more, but I've been really impressed about how quickly I've been able to access those services. And so, of course, the BSO is able to then do those very fulsome histories, and especially for patients and families who are like really wanting to have a very robust non-pharmacological approach, and they're willing to really work hard with the medical team to be able to try and implement that approach. I find reaching out to the Behavioral Supports Ontario is very helpful.
Thank you for
Una,
that.
yeah, go ahead and
I was
respond.
just going to say, do you need a diagnosis for to access BSO?
So I can't think of a time when I didn't. I'm trying to think of the form right now, and if there's a specific like box that I needed to check. You need to say specifically like the behaviors that you're asking for them to assess. Um, and everybody
Okay.
that I've sent has had dementia. I'm not sure if they would. Do you mean like will they see like people with other types of mental health
Yeah,
conditions
I
as
guess
well?
my
Or
perspective is I have both longitudinal practice and then I work in a memory clinic model.
Mhm.
And I have way more time in the memory clinic model and way more resourcing in terms of um, looking into symptoms by the time people get there. And it's great that I have this knowledge because it informs my practice, but it's time is still the essence, right? And so um, I find that, that first point of contact, often people are presenting, if things have sort of grumbled along, people are like, oh, this is normal aging and stuff. And it's really when these behaviors come out that people get alarmed. And I'm trying to think of ways that we can upskill caregivers that hopefully if there are some, because people without caregivers really are really, at risk, but how we can upskill people to come prepared with that information, um, like to sort of work with us in the time frame that we have, or what are ways that because even explaining, okay, I'm going to ask you all these questions about ABCs and like it just takes so long.
No, I know. And sorry, one more thing I should have said earlier too is, within our geriatric clinic, like we do have like a triage system. Like if it's an urgent referral, people do get seen much faster than our average clinic time. So please, those are the kinds of people that we would want to see in geriatrics clinics and things. And we don't, so, when I see somebody, it's a comprehensive geriatric assessment, or like what you would be seeing, Una, in your memory clinic practice, because it does take longer to be able to do those assessments and understand those things. And what we do find, at least, in our practice, is that those types of questions are things that we're asking people when they come, that we do really need to uh, spend the time with, like, one of our clinic nurses to be able to like ask the questions, because sometimes, you ask a question one way, and you ask it again, and then all of a sudden you get so much more information, or the first person asks and then the second person asks, and then you find out so much more information, that we don't have a really like a faster way necessarily. I don't know if there's somebody else here who has been able to implement like a process of, I don't know, I don't think pre-screening is necessarily the word I'm looking for, but before coming into clinic, if they're able to get more information on the phone, or to have like an electronic form that they try and do with families and caregivers, and what their experiences have been doing that.
Thanks, Jen. There's some stuff in the chat that I'm gonna sort of sort through here. So some people were asking, what is BSO? How do you access BSO? People are saying any behaviors related to major neurocognitive disorders are appropriate for referral to BSO. And Liz, you made a suggestion here about linking people with community supports early on in this disease, such as an outpatient geriatrics clinic or community geriatrics clinic, if there are treatable behaviors, and link caregivers to community supports early on. I think that's a great suggestion. Um, there is a question. How would you suggest training non-regulated healthcare workers, such as PSWs, on identifying delirium symptoms?
So first part, I'll just get back. I'm going to share my screen again. I actually have the form here. So the behavioral supports is available to people in Ontario, but I understand that if you're in other provinces, there may be similar resources that go by a different name. So you'll have to sort of see if this all sounds familiar to you, and to see about the wait times for your service that's available closer to you. I have to say, sort of like the last patient that I referred to behavioral supports in Toronto, in Ontario, I got an email back from them. It was within a couple of days, and they were asking like clarifying questions, so they'd be able to start helping my patient. And in response to somebody's question from before that I couldn't remember, they do ask for an explicit yes, no, or unknown suspected for a dementia diagnosis, and then you have to put in the specific behaviors that you're concerned about. And then actually, when I got my email back, it was, they wanted more detail and more information about the behavior itself. And then you can, of course, include other medical information that you have as well, to be able to support the team in helping your patient. In terms of education, to be able to help non-regulated health professionals, of course, this is a great interest, to I think everyone in geriatrics, because of course, there's, the existing health human resources are very stretched, and we're trying to think of like new and creative ways to be able to engage people in caring for older adults. And so, I know that at the moment people are trying to develop more curricula for personal support workers, also other people like social service workers who, of course, as you'll know, they're college trained, to be able to support people in the community, especially with linking to community resources, also interested in helping them to be able to support people with dementia as well. In terms of identifying delirium, whenever we're I'm thinking to, St. Michael's Hospital, for example, we have care aides, people who have a personal support worker background who are caring for some of the people with dementia. And they do, programming that is specifically meant to help them to learn, like the gentle persuasive approach, for example, and to be able to use those like ABC charting type approaches to be able to describe the behaviors, and then also to be able to, reach out to the nurses, but also the physician staff as well, whenever they notice those acute changes. So then, at least as it works here in the hospital, it's often, the nurse then who is sort of raising the alarm, is this actually a delirium? Do we need to do more workup? Or, the physician who is talking to the personal support worker who then, initiates that process of looking for potential causes of delirium.
That's great. Thanks, Jen. There's a comment from, as Jen just said, BSO is limited to Ontario, but there are similar programs in other provinces. And Jennifer Luke's just put in the chat, in Nova Scotia, they're behavioral resource consultants through the continuing care program. So that's really helpful. And if you have something similar in your province and you want to point that out, we can collect those in the chat, and just keep an eye out for your own province if you are looking for that sort of resource. Resources for caregivers, no respite services in Penny's region. Jen, do you want to speak to that? I can answer the question about the curriculum, but
Okay, so the question is around like what to do when there aren't respite
yeah.
resources for that's very challenging. Um, and especially if, somebody is like new Canadian without that sort of potentially without that larger network of people to be able to support them, or they've had to like move to a new area and they're isolated from, other potential family and friend caregivers who can help them. That's really hard. However, through the, in Ontario, what we would call now it's Ontario Health at Home. There may be access to something like a day program, for example, which may not give you that overnight, like that full 24-hour support or 24-hour reprieve from the burden and distress that the caregiver may be experiencing, but at least may give you, time during the day or give the caregiver time during the day to be able to do something that will help to relieve their stress or to do other activities that they need to do that they can't do whenever they have the person with dementia with them.
We do not have a session scheduled in this particular Echo series about resources or caregiver support or anything. Flex session, and we will be asking you to vote on what you want us to cover in that session. One of the options is caregiver support. So if that's something that you're interested in, please keep an eye out for that. And CCSMH is our partner for this Echo. They have a really, really excellent behaviors in dementia toolkit that links to all sorts of resources and the tons of stuff. It's a huge library of content. That may be a place to turn to as well, if you're looking to point caregivers somewhere. Okay, I'm just looking, there's more comments about behavior management options. Jack made a comment about more than curricula, we need coaching and small group sessions. I don't disagree. Yes, I will put that in the chat. Absolutely.